Hey guys, Dr. Brandon Crawford here. I'm the founder of the Austin Center for Developing Minds. We are located just north of Austin, Texas in Cedar Park. And what we do is we focus on developmental functional neurology. Hopefully you'll have a chance to catch my lecture because I'm going to be taking you through what that process looks like and why it's so important to focus on rehabbing the brain in the right way, at the right time, with the right frequency and oscillations and all this kind of stuff, right? So I'm very honored to be a part of this conference. This conference is very meaningful. I love all the people involved, and obviously the cause is fantastic. So thank you again, and I look forward to seeing you soon.
Due to advances in technology and bioscience, the most efficient ways emerging to treat pain and injury revolve around the nervous system. Using the human body's amazing ability called neuroplasticity, it is now possible to activate increased strength, pain-free movement, and faster healing. This is the Newbie device, a patented electrical stimulation device used for neuromuscular re-education. While conventional treatments for pain and injury only manage symptoms, the Newbie device allows you to work at the source of the problem. Using this approach, 90% of individuals notice meaningful progress in the very first session, and evidence is showing those early results also lead to faster overall recovery from most injuries and surgeries. There's finally help for people having difficulty recovering from injury, living with chronic pain, or experiencing challenging neurological conditions. Ask your doctor or therapist about the Newbie from NewFit, accessing the power of the nervous system to improve outcomes.
Cullen Gibbs, and I'm happy to be speaking with you today about returning to school after brain injury. Just to tell you a little bit about myself, I've been with TIRR Memorial Hermann in Houston for 10 years now. I work primarily with children and adolescents with a focus on brain injury, traumatic brain injury, and a variety of other sort of neurodevelopmental conditions and that kind of thing. So I'd like to tell you a little bit about what we're going to be talking about today. So we're going to be talking about changes that students with brain injury experience subsequent to their injury. We'll be talking about recovery and treatment. Of course, we'll be talking about returning to school and that process. And involved in that process, preparing faculty and classmates, and preparing the family and student, and other roles for school rehabilitation therapists or other people who may be working with the student when they return to school. I hope that this presentation has enough information to be useful to all the participants, including parents, educators, persons who may be in the medical field or rehabilitation field. Hopefully this will have some relevance to all of you. So let's start by talking about changes experienced by students with brain injury. So certainly there can be physical changes. I have some listed here. This is not comprehensive, but they can be a myriad of different things that occur following a traumatic brain injury. Changes in walking, difficulty with fine motor skills, changes in vision and hearing, headaches, seizures, poor control of the bowel and bladder. These are all different physical changes that can occur. We also have cognitive changes. So there are a variety of cognitive changes as well. So oftentimes there's changes in short-term memory, reduced concentration, difficulties with multitasking, following multiple step instructions, changes with problem solving, more difficulty with abstract thinking, organization, being able to retrieve words or word finding, goal setting, task monitoring, planning, generalizing information. There are a lot of different changes in the way that persons think that occur after a brain injury. There are also psychosocial changes, and these changes can occur from the primary sort of physical damage to areas of the brain responsible for behavioral and emotional functioning. Also, there may be pre-existing disposition to emotional difficulties. And then, of course, there are changes. So certainly there can be changes in behavioral and emotional functioning as part of this. So we know that children with brain injury are at increased risk for later psychiatric diagnoses, such as oppositional defiant disorder, major depressive disorder, and generalized anxiety disorder. There are also frequently changes in social functioning. Research shows that children with traumatic brain injury tend to be less socially competent and lonelier than children without brain injuries. Also, persons with brain injury may have deficits in understanding emotion, mental states, and struggle with social problem solving. So when we think about all of the different changes that may occur following a traumatic brain injury, we definitely need to be mindful and thoughtful about how we reintegrate the student into school, and being aware of the physical, cognitive, and psychosocial needs of the student. So typically, when a student is initially returning to school, so let's say they've been discharged from acute care or discharged from inpatient rehabilitation, there can be homebound instruction put in place. So most students with moderate to severe brain injury will not be ready to immediately return back to campus. That can be too much demands on the student. And so homebound instruction allows these students to participate academically while providing additional time for recovery and rehabilitation. Homebound instruction is understood as being temporary until an appropriate educational plan can be developed. Homebound instruction can also be helpful because the instructor can communicate with other school personnel about processing issues, learning needs, and effective strategies in working with the student. So when we think about returning the student to school, and we're going to start developing a more formal plan, we have to think about, what are the health-related needs that the student is going to have? Is there any necessary medical equipment? What kind of safety precautions need to be put into place? Are there seizures? And if so, how are they controlled? Is there changes in motor functioning, such as spasticity? Does the patient have headaches? How are they treated? Any other forms of pain? Is the need for a medical procedure during the day? Is medication needed? And what are the possible side effects? Does the student have stamina for a full day of classwork? If they do we still need to be mindful of providing rest periods during the day? And have there been any changes in visual or auditory processing? We also need to consider any self-help needs. So things that we're talking about here are, does the child need assistance with eating, toileting, putting on or removing clothing or outerwear, such as gym clothes, being able to access the locker in middle school or high school, and then assistance with performing, other activities of daily living during the school day. What about mobility needs? Is the student able to, ambulate freely and safely in the school environment? Do they need a barrier-free environment, being mindful of, different things that may interfere with their ability to get around the school? Do they need assistance with transfers? So transfers meaning, getting into a desk or getting out of a desk, that kind of thing. And is there any need for some special equipment that may assist with mobility? In-school therapies. There can be a variety of things that a student can have access to depending upon their needs. So certainly there can be educationally relevant speech, occupational and/or physical therapy, medically necessary therapies, psychological counseling, and assistive technology. So these are all things that could be available to a student when they return to campus. Communication needs. Does a student need some sort of augmentative technology to help them with communication? So it could be something as simple as having access, depending on the child's communication, maybe a sign language interpreter or that kind of thing. Then, of course, we also need to be mindful of behavior and supervision needs. Regarding behavior, does the student need a behavior modification plan? So this would be a plan that would be put in place that would hopefully reinforce positive behaviors, provide structure, and reinforcement of what we want to see to support that student behaviorally. Is there a person to oversee and monitor the plan, so a school psychologist or someone along those lines? Would the student need a classroom or individual aid in order to help manage behavior? And then, of course, what type of structure do we need for the student? And we need to be mindful of what type of structure and the amount of structure that may be needed. Also, when we think about supervision, we need to be mindful of unstructured times, like before school, during recess, changing classes, lunch, those times that are less structured, less supervised. Do we need to have someone there to support that for the student? Do we need to have increased structure within the classroom or queuing to provide some recognition to the student that something is taking place that's important or that kind of thing? And so we need to be mindful of these as well. So, once we've been thoughtful and mindful about all of the supports that a student may require upon returning to school, then we need to think about, okay, how are we going to prepare all of the important individuals for this important transition? And so first, we'll talk about ways to prepare school staff and classmates. So we need to be sure that all of the staff who are working with the student are informed and understand the brain injury and what to expect upon the student returning to school. Oftentimes, hospital or rehabilitation staff will welcome the opportunity to visit the school and provide information about brain injury. School nurse is certainly someone within the school that's knowledgeable about medical terminology and the physiological basis of the changes caused by brain injury. And so the school nurse can be a very excellent resource in this regard. It's also important for school staff to understand that deficits or changes that occur in the student are not the result of laziness or a lack of discipline or malingering. They need to understand that these changes are related to the actual injury to the brain and the changes in behavior that occurred subsequent to that. We also need to be mindful of discussing any changes in the student's appearance or ability to get around the school. Occasionally, a student may return to school subsequent to a craniotomy, so there might be a scar that's apparent, or maybe they've removed part of the skull to allow for swelling, and this has not, the skull flap has not been returned. And so the student may have to wear a helmet or something just to protect their head. And so all of these things need to be discussed ahead of time. School staff need to understand any behavioral and communication strategies that are helpful for working with the student. So for instance, how information or directions should be presented to the student, methods for handling any assistive equipment, and certainly staff need opportunities to have any questions or concerns addressed so that they know what to expect. So then we want to talk about, how do we help the classmates, the peers of the student? What type of information is important to share with them? Well, certainly we want to talk to the actual student and the family to determine what information, if any, they want shared with peers. But sharing information with peers can be very helpful because there can be a lot of misconceptions. So classmates may think that the student's return to school after brain injury means full recovery, so that the student is going to be exactly the way that they were before. Peers may reject the student who is not fully recovered unless they are helped to understand what differences may exist. And peer acceptance can be facilitated if peers understand how the brain injury has affected the student. Some helpful strategies include creating a circle of friends. Some classmates of the student who are friends or otherwise mature classmates to kind of help support that student in their reintegration into the student body. Someone who is comfortable and knowledgeable about the student with a brain injury is the ideal person to talk to friends and classmates. This can be the parent of the student, an older sibling, a teacher, or other professional from the rehabilitation or medical staff. Peers are more likely to become comfortable with the student if they are given information and have questions and concerns addressed and answered. Common questions asked by peers are, how much will he understand? Should I talk slowly or louder? Will she be able to walk, talk, and eat by herself? Just what should we expect and how should we treat him? So then we also need to think about how are we going to prepare the student and their family for this transition. So in preparing the family, we need to talk to them about the various services that are available to them. So we have, services can be provided through special education or through Section 504. And then we'll talk about the special services that can be accessed, and then development of a individual education plan or a 504 plan. Certainly, we want to be mindful of this. 504 provides accommodations, but not necessarily interventions. I think that 504 accommodations are best suited for students returning to school after brain injury with minimal changes or impact. So maybe they have ongoing short-term memory problems and attention problems and that kind of thing that can be supported by some simple strategies such as being mindful of where they're sitting in the classroom and giving the student reminders and that kind of thing. If a student has more serious needs, though, we need to think about providing special education services through the development of an individual education plan that will not only provide for accommodations, but also provide for any necessary interventions that might occur during the school day. Interventions, could be anything from speech, occupational, or physical therapy, medical necessary interventions, interventions to support cognitive or psychosocial functioning, that kind of thing. And so for students who are experiencing more serious changes after their brain injury, we definitely recommend special education and the development of an individual education plan. If a student has had a traumatic brain injury, then there is a category of special education services called traumatic brain injury, and that would be the right categorization for the student. Some students may have had something like a stroke, maybe secondary to a ruptured aneurysm or something along those lines. Traumatic brain injury may not be the appropriate categorization, but there's another categorization called other health impairment under which that could fall. And so we just want to, be mindful of, the appropriate categories available to serving students who require special education services, and being mindful that the student is receiving those services in the appropriate category. Certainly, we want to promote family participation. Parents are the expert on their child. They're a vital link between connecting the rehabilitation staff and the school system. Active participation of families should be encouraged, and the family should be, an active part of developing the school reentry plan. This is a very important process, and the more that the families are involved, typically the smoother things will go. So we also want to prepare the student. So we want to share and review the plan with the student using developmentally appropriate terms. Even when returning to a familiar school, concrete strategies such as touring the school to review the physical layout and renewal of acquaintances can be helpful. And so, basically that means going to the school prior to actually, their first day back in the classroom to just sort of refamiliarize themselves with the school building, where things are, meeting with teachers and students and that kind of thing can be helpful. We certainly want to monitor the transition. So this is where communication takes place. We want to have ongoing active communication with family, teachers, peers, and the student on a periodic basis after the student returns to school, just to be sure that things are going well, that nothing has been missed, that services are being provided as recommended in the individual education plan, and then hopefully catching any issues early on in the process and then being able to make adjustments for those issues in a more proactive rather than reactive manner. So most children who have had a brain injury will have, some experience working with a rehabilitation team. This includes physical, occupational, physical therapy, could be a physiatrist or the physician, neurologist who is working with the student, as part of their brain injury care, psychologists, of course, or social workers. All of these individuals can be valuable resources. It's important to remember that rehabilitation therapists have expertise in medical conditions that school personnel may not. So therefore, the rehabilitation therapist can help school personnel better understand the nature of the student's needs, contribute to planning necessary accommodations and interventions, and share what's been learned from working with the student. So chances are, the therapist has been working several times a week for several hours a week with the student, and they will have a good understanding of what this child's needs are when they get back to school. And this can be communicated to school personnel and be very useful. And I think it's just good continuity of care that all of the professionals, both in school and in the medical area, are working together to support the student and to be sure that this return to school goes smoothly and that the important areas are being addressed. So things that can be shared by occupational therapy. Needs for any accommodations or strategies to address issues such as eating, toileting, writing, putting on or removing outerwear, accessing lockers, performing other activities of daily living. These are things that occupational therapists are typically working with patients on. Physical therapy. So they can share information about mobility needs, need for a barrier-free environment, assistance with transfers, any special equipment that's needed for getting around the school, the need to access the elevator rather than the stairs, the need for extra time between classes, to assist with transfer and that kind of thing. So the physical therapist will have excellent information in this area. Speech therapy. So the speech therapy will have a good understanding of any difficulties the student has with speech and motor control, such as slurred speech, difficulties with eating and swallowing, difficulties with cognitive and communication needs and what needs to be done there, any need for augmentative technology, and other assistive technology as needed. At TIRR Memorial Hermann, we have the Return to School program. And basically, this is a multidisciplinary team that includes physical therapists, occupational therapists, speech and language pathologists, neuropsychology, and a licensed clinical social worker. This program addresses strategies for attention, memory, and problem solving, improving communication, social and emotional adjustment, recommend and training on assistive technology, any assistance necessary with bowel or bladder management, improving mobility, increasing independence with activities of daily living, how to negotiate the school environment with assistive devices, addressing any feeding issues, improving strength and activity tolerance, and increasing inclusion in play and leisure activities, and then of course, educating and assisting school staff. So it's a comprehensive return to school program for students with brain injuries. We try to focus on addressing the concerns facing children and families when returning to school following a brain injury. The overall purpose of the program is to build strength and endurance, increase independence, teach new skills, and improve the confidence in the children who need assistance in returning to school. Here is the contact information for the Return to School program. It occurs at our Kirby Glen location on South Braeswood in Houston. And this program is geared towards specifically students with brain injury, but it does not necessarily have to be a traumatic brain injury. So students who have experienced stroke, or maybe they've had surgical intervention secondary to a brain tumor or a seizure or that kind of thing. Those students would also be appropriate for this program, and they have similar changes or issues that a student with a brain injury may experience. Also, students who have multiple sclerosis or other sort of medical conditions that require some level of intervention or rehabilitation. In general, this program would be for students, after they've been discharged from acute care or inpatient rehabilitation, and it would be part of intervention that occurs in between discharge and then returning to school. So the therapies would occur in trying to get the student prepared for school, and then we would try to assist and work with the school in order to get that student successfully transitioned back to the school program. Oftentimes, students will participate in homebound instruction during this period. But homebound instruction is flexible enough that it allows participation in several days a week, several hours a week of therapy. And then once the therapies are reducing in frequency and the student is ready to return to school, then that assistance is provided with that process. So here are some references that I utilized in putting together this presentation. Thank you very much for your attention. Of course, I'm happy to field any questions that participants may have. A little bit more about TIRR Memorial Hermann. Certainly a big focus on what we do is research. We have good results and outcomes for patients who come to see us. So for instance, 100% of adolescent clients who completed our return to school program returned to school by discharge. We're nationally ranked. We're almost always ranked in the top 3 of rehabilitation hospitals in the country. Our therapists are very well trained and have certifications in neurorehabilitation, rehabilitation nursing, and that kind of thing. And we have affiliation agreements with multiple universities and colleges. We definitely have a good volume of patients that we see every year. Over 2,000 inpatient patients are cared for, 34,000 outpatient therapy visits. And 25% of our referrals are national or international, so that means not local, coming from different areas of the country or internationally. Here's some of the sort of the foundation of what we do: clinical care, research, education, and advocacy. Here is one of our gyms at our inpatient facility. And there is our inpatient facility taken from street view. And that is everything. So once again, thank you so much for your attention and participation in this presentation. Like I said, if you have any questions or need additional information, feel free to contact me, and I will be happy to assist in any way that I can.